Cardiovascular disease is the leading cause of death and disability in India. WHO forecasts that by 2020 there will be a 120% increase in cardiovascular disease mortality in India. Clearly we know presently already that coronary heart disease is very prevalent, so much so that India is considered the coronary capital of the world. And this is happening largely due to the changing lifestyle, urbanization, lack of physical activity, which is quite widely prevalent. We have shown many years ago that when you look at a 15-year gap between same populations, the overall prevalence of metabolic syndrome has rapidly increased related to the increased rates of obesity. Clearly, most of it is preventable by better lifestyle management, and as physicians, we should be participant in prevention of these risk factors. There are many therapies that are available at the present time to treat patients who already have vascular disease. These include appropriate control of blood pressure with adequate medications and getting patients to target blood pressure goal. Also, it includes treatment of dyslipidemia, certainly with dietary interventions first, but in most cases dietary interventions don't work, and in those cases treatment with an effective lipid-lowering therapy, mostly by statin, could be highly effective. It's important to emphasize that for people of Indian origin, the LDL target should be at least 30 points lower as compared to Caucasians. For example, if somebody doesn't have any vascular disease, the LDL target in Indian patients should be less than 130. Those who have vascular disease, the LDL target should be below 100 or ideally close to 70, as we and others have shown in many studies that for secondary prevention, including those with vascular disease, diabetes, metabolic syndrome, the LDL should be lowered down to 70. Now it's also important to emphasize diabetes, which is also very prolific and prevalent in India and rapidly increasing, can be prevented by weight control, by lifestyle management, by some physical activity. It does not need to be strenuous, but something clearly such as daily walking for 30 to 35 minutes 5 times a week can have reduction in the incidence of diabetes by almost 50%, as shown in the Diabetes Prevention Project and the Finnish trial. Clearly, those who have already developed diabetes, we should be aggressive in treating them, but not too aggressive, as I'll point out tomorrow. Clearly, reducing hemoglobin A1C below 7, but not below 6.5 is beneficial. Aggressive control of blood pressure, but not below 120 is beneficial. And what is most effective is aggressive control of their lipids, including reducing LDL closer to 70, increasing HDL when feasible, and niacin is very effective therapy and should be utilized in diabetic patients. It's currently underutilized, and also when needed one can use fibrate, although the recent Accord study does not support its use. So I think overall I want to emphasize that most of the increase in cardiovascular disease in India is preventable by lifestyle intervention, but lifestyle interventions are hard to achieve and maintain, and in those cases then appropriate interventions to reduce blood pressure, smoking cessation, lifestyle management that includes dietary interventions, regular physical activity, weight reduction, and appropriate management of lipids and blood pressure are extremely useful, as shown by a number of large studies as well as recent meta-analysis of these trials. So I think as physicians we should be participant in this aggressive primary and secondary prevention strategy, and these can be easily achieved if we pay attention to our patients and measure the risk factor. One should not be bogged down to measuring unusual or emerging risk factors such as HSCRP, Lp(a), or things like that. They may be useful in a selected group of patients, but in population at large these measures are not needed and certainly a waste of energy. Last but not the least, I want to emphasize that in India there's too many interventions are being done. As we have shown in the COURAGE study and more recently in the NIH Berry 2D trial, it's quite evident that optimal medical therapy, that is getting all of the risk factors at goal, is as effective as doing angioplasty or bypass surgery. And clearly that is something we should be implementing rather than pushing everybody towards angiography, angioplasty or bypass surgery. Thank you very much.